everybody, this is Dr. Chitra, your mentor at StudyMEDIC and StudyMRCOG. And since part 1 exam is around the corner, we are back with our new RRR series in our attempt to help you to clear this exam. So today I'm going to be talking to you about the module Pathology, in particular CA endometrium, the staging, the women who are at a high risk of developing CA endometrium, and a little bit about the management options, because these are the type of questions that are commonly asked in the exam. Now, remember one thing, pathology is a huge module. Expect around 20 to 25 questions from this module. And whenever there is a new update, like the FIGO classification, they have revised the classification in 2023. So whenever any new classification comes up or there is any new guideline, then in the exam, you would always be getting more type of, expect a few more questions from that particular update that has come. All right. So we know that carcinoma of the endometrium is very closely linked to endometrial hyperplasia. And the type of women that are at high risk of developing endometrial hyperplasia is anyone who has an estrogen excess. So women, those who have a high BMI, those who are known cases of PCOS, women who have never used any type of contraception in the past, those who have infertility, there is chronic anovulation. And then women, those who have had an early menarche, late menopause. So whenever the endometrium is exposed to prolonged periods of estrogen, and especially unopposed estrogen, that means there is no progesterone. So that is why chronic anovulation. These are the type of women, those who are at a high risk of developing endometrial hyperplasia. And in endometrial hyperplasia also, certain types are at a risk of developing into invasive cancers. So according to the latest classification, endometrial hyperplasia is divided into two types: endometrial hyperplasia without atypia and atypical hyperplasia. Now, for endometrial hyperplasia without atypia, the risk of progression to cancer is less than 5% over 20 years. So we know that most of the women, those who have endometrial hyperplasia without atypia, they will not progress. Most of them regress back into not having endometrial hyperplasia. Whereas those women who have atypical hyperplasia, okay, for these women, if the hyperplasia is not treated, then the risk of that endometrial hyperplasia developing into invasive cancer is 8% in 4 years. It rises to 12.4 in after 9 years, and it becomes 27.5 after 19 years. The important thing that you have to remember is that women, those who undergo hysterectomy for atypical hyperplasia, the risk that there is concomitant invasive cancer in these women who have atypical hyperplasia and those who are undergoing hysterectomy is as high as 43%. So it's very important that women, those who have atypical hyperplasia, be treated aggressively. Okay. Now coming to women, those who have invasive cancers or CA endometrium, there are a lot of histological types. We will be seeing that in the next slide. And also CA endometrium, there are two types that are seen commonly, type 1 and type 2. Okay. We already saw that carcinoma of the endometrium is associated with hyperestrogenism. So these are type 1 tumors that are associated with hyperestrogenism. These are normally low-grade tumors. The age and diagnosis is relatively younger women. Okay, CA endometrium is usually a disease of older age, we know. For type 1, the incidence rises sharply from 40 years of age. The histological type is usually endometrioid, and they have a good prognosis. So type 1 tumors have good prognosis. That is what you have to remember. Now, type 2 is the one that is not associated with hyperestrogenism, and it is usually seen in older women, more than 70-75 years of age. That is the type where you will see type 2 tumors. These are usually high-grade tumors. So you have papillary, serous, or clear cell tumors, and the prognosis is relatively poor for type 2. Okay. Now coming to the histological types. So the types that you have endometrioid called as EEC, low grade and high grade. So 1 and 2 are low grade, high grade is 3. Serous carcinoma, clear cell carcinoma, mixed carcinoma, undifferentiated carcinomas, carcinosarcoma, mesonephric-like, and gastrointestinal mucinous type. These are the other histological types. Now, why is it important to know the histological type? Because some of them are non-aggressive and others are aggressive. And even this is counted for when you do the staging. The new FIGO 2023 staging takes into account what is the histological type of tumor. So whenever it is endometrioid, low grade, that is grade 1 and 2, these tumors are considered to be non-aggressive. Whereas endometrioid grade 3, then you have serous carcinoma, clear cell carcinoma, mixed carcinoma, undifferentiated, carcinosarcoma, mesonephric type, and GI mucinous type. All these are aggressive tumors. Okay, so automatically the staging is going to be upgraded whenever you have this histological type. Now, a new thing that is there in the FIGO 2023 classification is that molecular classification is done. And it is usually done for high-grade endometrioid carcinomas. Okay. So whenever you have the pole mute classification, usually if it is early stage disease, the prognosis is excellent for this histological type. Whereas those who have P53 mutation, they are considered to have a bad prognosis. Now, let us see the FIGO staging. What is new in this 2023 FIGO staging? Because you are asked sometimes questions like a scenario would be given, and then you have to say what particular stage of carcinoma this lady has. So, you have to be very thorough with the staging. Okay, not only for endometrium, but cervical is another staging which you have to be very thorough with. As usually with all stages of carcinomas, we know that whenever the carcinoma is limited to that particular organ, okay, there is no invasion, it is called as stage 1. So similarly in this CA endometrium, stage 1 is whenever it is confined to the uterine corpus, remember corpus, and even ovary. Low histological types, if they are there and it is confined to the ovary, it is classified as stage 1. Okay. Now in stage 1 also we know there is stage 1A, 1B and 1C. Whenever the histological type is aggressive, it is usually grade 3C. So 1A, okay, remember stage 1, it is one that is confined to the uterine corpus, okay, not cervix, uterine corpus, and to the ovary, it is stage 1. Now, what is stage 1A? The disease is limited to the endometrium only. Even myometrium is not there. Then it is stage 1. Why? Because this is CA endometrium. Okay, so whenever it is limited to the endometrium, and it is non-aggressive histological type. We already saw which are the histological types that are non-aggressive. Or invasion is less than half of myometrium. That is less than 50% of the myometrium is involved. And there is no focal LVSI. LVSI means lymphovascular space involvement. Or there is good prognosis disease like we saw. Endometrioid with pole mute, that is a good stage disease. Okay, the prognosis for that mutation is good. So 1A, we know endometrium or less than half of the myometrium, no focal LVSI, and good prognosis disease. Now, what is 1A1? Whenever it is non-aggressive histological type, okay, limited to an endometrial polyp or confined to the endometrium. So even if it is there in the polyp, you will still say it is stage 1A1. Okay. 1A2. Of course, stage 1, it will always be non-aggressive histological types. Okay. It involves less than half of the myometrium, no focal LVSI. Stage 1A2. What is 1A3? Okay. Low-grade endometrioid carcinomas. Low-grade means 1 or 2. And they are limited to the uterus and ovary. So even if it is involvement of the ovary, but the histological type is low-grade, then it is 1A3. This is very important to remember. Okay. Now 1B. So it is, of course, again, non-aggressive histological type with invasion of half or more than half of the myometrium, no focal LVSI. So remember 1B, again, it is confined to the uterus. Okay. More than half of the myometrium is involved. It will be 1B. 1C, any aggressive histological type. So anything other than grade 1 or 2 endometrioid. Even if it is limited to the uterus or to the endometrium, but the histological type is aggressive type. Okay. It is limited to a polyp or confined to the endometrium. It will be 1C. So whenever, like I said, histology is aggressive, the tumor gets upgraded. Now, stage 2 of any disease is whenever any surrounding structures are involved. So similarly for stage C endometrium, whenever you have stage 2, okay, there is invasion of the cervical stroma. Remember, cervical stroma, not cervical glandular invasion. Okay. Invasion of cervical stroma with extrauterine extension, or there is LVSI or aggressive histological types with myometrial invasion. This becomes stage 2. In that also, 2A means there is invasion, only cervical stromal invasion, or non-aggressive. It should be non-aggressive histological type. 2B, whenever there is LVSI of non-aggressive histological type. And 2C means any aggressive histology, anything other than endometrioid grade 1 or 2, and with any type of myometrial invasion. It becomes stage 2C. Okay. Now stage 3. Remember, whenever there is any locoregional spread, that means any pelvic lymph nodes or surrounding to the local structures. Okay. And any histological subtype, whether it is low grade or it is high grade, it is aggressive or non-aggressive. Whenever there is local spread, it becomes stage 3. Now in this also you have stage 3A, 3B and 3C. So 3A, whenever the serosa is involved, so the endometrium, myometrium, and it has reached up to the serosa now. Okay. And from the serosa, the adnexa have also been involved, or both serosa and adnexa, and there is direct extension or there is metastasis. Then it becomes stage 3A. 3A1 is when there is spread to the ovary or the fallopian tube. Okay, except when it is meeting stage 1A3 criteria. That means it is low grade disease and it is involving the ovary, then it is stage 1A3. Okay, but what happens in 3A? The disease is histologically aggressive type and it is going to the ovary, then automatically it becomes stage 1A1, 3A1. Okay. 3A2 is involvement of the uterine serosa or spread through the that means it has breached the uterine serosa and it has spread to surrounding structures. Remember, Stage 3, usually you will have all high-grade tumors. Okay. Now stage 3B, whenever there is metastasis or there is direct spread either to the structures lower down. So vagina or to the surrounding structures, parametrium or the pelvic peritoneum. 3B1 is metastasis or direct spread to the vagina and or the parametria. Stage 3B2 is to the pelvic peritoneum. Now, whenever lymph nodes are involved, it becomes stage 3C. In this also you have 3C1, where you have micromets and macromets. That means stage 3C1 is mets to the pelvic lymph nodes. 3C2 is to the para-aortic lymph nodes up to the renal vessels, with or without mets to the pelvic. Okay. Whenever it is micro, it is called as stage 3C11, and whenever it is macro, it is stage 3C12. And what is stage 3C2 means whenever it goes up to the para-aortic lymph nodes, but only up to the renal vessels. There also you have micromets and macromets. Stage 4 is any disease that has spread far away. So, and remember, for this far away spread, it has to, like any organ that is affected, it has to be mucosal affection, not serosal. If it is only serosal affection, it becomes stage 3 disease. Whenever the bladder mucosa is involved, or intestinal mucosa is involved, or any distant metastasis, then it becomes stage 4. So stage 4A, there is invasion of the bladder mucosa and or intestinal or bowel mucosa. 4B is abdominal metastasis beyond the pelvis, whenever it has spread beyond the pelvis. 4C is distant mets, including mets to extra or intra-abdominal lymph nodes above renal vessels. Whenever it is up to the renal vessels, lymph nodes are involved, we saw it is stage 3C. Above the renal vessels, it becomes stage 4. And spread to the lung, liver, brain, or bone, that becomes stage 4. Okay, I know this is a little bit complicated, but this slide should go on your study wall. Keep reading it every day for a period of 7 to 8 days. At the end of the 7th day, it will be firmly fixed in your brain. You need not go on reading it again. Okay. Now, this is what I was talking to you about the molecular classification. So remember, whenever it is a pole mute classification, usually the prognosis is very excellent. Whenever the mutation is P53, usually the prognosis is not so very good. You need not remember this in too much of detail. It is only for your extra knowledge. Now, how do you remember this? I tried to make it a little bit easy for you. Okay. So how do you decide? Remember, whenever it is non-aggressive histology, that means it is low-grade endometrioid, grade 1 to 2, no focal LVSI, it is, you know that it is a low-grade disease and it is usually stage 1. Okay. So first thing, whenever you are staging, first have a look at the histology. See whether it has spread anywhere and whether the LVSI is involved or not. So whenever non-aggressive, we know it is endometrioid, grade 1 or 2, and grade 3 is aggressive, and all the others are definitely aggressive. So whenever histology is aggressive, the staging gets updated, upstaged. Now, stage 1, whenever it is confined to the uterus and or ovary, and 1A, good prognosis, less than 50% of myometrial invasion, or it is confined to the endometrium or polyp, no focal LVSI, and it is low grade. That means endometrioid grade 1 or 2. Okay, 1A1, polyp or endometrium only is involved. 1A2, less than 50% of myometrium. Myometrium invasion is there, but less than 50%. Now, stage 1A3, again, low-grade disease, okay, endometrioid, specifically endometrioid, if it is limited to the uterus and ovary. Even though it has gone to the ovary, but it is still low grade. It still becomes 1A3. Okay. 1B, more than 50% of myometrial invasion. Again, histology has to be non-aggressive. Please remember, stage 1, any histology which is non-aggressive. If it is aggressive histology, it gets upstaged. Okay. So 1C, whenever histology is aggressive, even though it is confined to the polyp or it is confined only to the endometrium, if the histology is aggressive, you will still say it is 1C. Okay, so whenever it is serous, we know it is aggressive histology. No invasion seen anywhere, it is only in the polyp, but still it will be stage 1C. Okay, I hope now stage 1C is clear to all of you. Now stage 2. So whenever it goes to the cervix, remember it has to be stromal invasion. Glandular invasion of the cervix is not considered. Or there is LVSI, or the tumor is aggressive and there is invasion. So 2A, there is cervical stromal invasion and it is non-aggressive histology. Stage 2B, there is substantial LVSI, non-aggressive histology. 2C, aggressive histology, any myometrial invasion. Okay. Cervical glandular invasion, remember, it is not stage 2. Only when there is cervical stromal invasion, it is called as stage 2. Okay. What is stage 3? Any local or regional spread. So whenever serosa gets involved or there is adnasal involvement, it becomes, so ovary tube is stage 3A1, serosa is stage 3A2. 3B, surrounding structures. So vaginal involvement, parametrial involvement or pelvic peritoneum. And when the nodes get involved, it is stage 3C. So when C1 is when pelvic nodes are involved, C2 whenever para-aortic nodes are involved. Okay. So one thing you have to remember, any nodal involvement is there, it automatically becomes stage 3C. So if it is only pelvic, it will become C1. Pelvic plus para-aortic or only even para-aortic nodes are there, but up to the level of the renal pelvis. Then it becomes stage 3C2. What is stage 4 disease? So distant spread or mucosal spread. Bladder mucosa, bowel mucosa, stage 4. Peritoneal mets beyond the pelvis, that means abdominal. And distant metastasis, lung, liver, brain, bone, and anything above the renal vessels. That becomes stage 4C. Okay. So I hope that now the staging has become clear to all of you. Let us see what are the management options that are there, because a little bit of management also you will sometimes be asked. So whenever this cancer is of low risk, so it is stage 1A1 or 1A2, you will do total abdominal hysterectomy plus bilateral salpingo-oophorectomy only. Okay. Even then, so these are the low risk ones. Those which are intermediate, that means 1B or 2A. For them, surgery, of course, yes, and plus or minus you can offer them radiotherapy. Those which are high risk, so aggressive types, 1C, 2C, 3 and 4. For them, yes, surgery, chemo, plus or minus radiotherapy. Okay, these are the options. So remember, only when it is low risk, you will offer surgery only. When it becomes intermediate, you will add radiotherapy, and those which are high risk, you will do surgery, chemotherapy, and plus or minus radiotherapy. Important things to remember in the exam. Whenever the histology is aggressive, you will upstage the staging. Stromal invasion, cervical stromal invasion, automatically it becomes stage 2. Any lymph node is involved, it becomes stage 3C. Bladder, bowel, mucosa involvement is stage 4. And ovary is involved. Okay, ovary is involved. You will immediately think it has spread and it is stage 3. But remember, at that point of time, see what is the histological type. If it is non-aggressive or it is endometrioid grade 1 or 2, even though the ovary is involved, it still becomes stage 1A3. Okay, very important point to remember when you are answering the SBAs. Now let us see a few typical SBAs that you could be asked in your exam. So you have this 58-year-old postmenopausal lady who presents with postmenopausal bleeding. A biopsy is done for her and it shows that she has endometrium cancer, but it is grade 1 endometrioid adenocarcinoma. Okay. An MRI is done, which shows that the disease is confined to the endometrium. It is arising from an endometrial polyp. There is no myometrial invasion and there is no LVSI. What is the FIGO stage for her? So, like we saw, what is the histological type? It is grade 1 endometrioid. That means if it is grade 1 endometrioid, it is non-aggressive. Okay. MRI is showing that it is confined only to the endometrium, no myometrial invasion. And it is confined to the endometrial polyp and no LVSI. So it is basically confined only to the polyp. Definitely, what would your answer be? It is definitely not stage 2, 3, or 4. It is definitely stage 1. Now, in this also, whether it is stage 1B or 1A, what would your answer be? Think about it and then see what is the answer. So, it is stage 1A1. Why? Because it is non-aggressive histology and it is limited to the it is confined basically to the endometrium. There is no myometrial invasion. 1B means less than 50%, it will be 1B. But here there is no myometrial invasion. So that is why it is stage 1A1. Okay, so this is a classical low risk disease. Another question would be like you have again this. So remember, most of them with endometrium, usually they will be coming with postmenopausal bleeding. So another one, she is diagnosed with grade 1 endometrioid adenocarcinoma. So immediately it should come to your mind. Grade 1 means the histology is non-aggressive type. But MRI is showing invasion of the myometrium. More than 50% of the myometrium is involved. There is no LVSI. And cervix and adenoids are normal. So what is the most appropriate type? Definitely, it has not gone beyond the uterus. Serosa is not involved. So it is definitely not 3. It could either be stage 2 or it could be stage 1. But if you see the myometrium, it is less than 50% of the myometrium. It is more than 50% of the myometrium. So the answer is again stage 1B because serosa is not involved and it is again low grade. Okay, grade 1 endometrioid. Okay, there is no focal LVSI and more than 50% of myometrium, but no serosal involvement is there. And cervix also is not involved. So it doesn't become stage 2. Now you have this woman, 66-year-old with a uterine sarcoma on endometrial biopsy, and MRI shows that the tumor is confined to the endometrium. There is no myometrial invasion. So yes, excellent. Only to the endometrium, no spread outside. But remember, what is the histology? It is serous. Now remember, serous carcinoma is something which is aggressive. So what would be, remember, whenever the histology is aggressive, you will upstage it. So that is why here it is stage 1C. Even though it is limited to the uterus, limited only to the endometrium, because the histology is aggressive, it automatically becomes stage 1C. Okay. Now you have this woman, she has undergone a hysterectomy for endometrial cancer. Histology is showing that she has grade 1 endometrioid carcinoma, grade 1 again endometrioid, with invasion into the cervical stroma. No extrauterine disease and LVSI is absent. So what would be the stage? Remember, there is cervical stromal invasion. Okay. Whenever there is cervical stromal invasion, it becomes stage 2A. Okay. Okay. So remember that invasion of the cervical stroma, it is non-aggressive histology. Okay. If it was vaginal or parametrial, then it would go into 3B. But here only cervical stroma and low grade. So it is still stage 2B. Now coming to some of the management options. So you have this 55-year-old woman, stage 1A1, grade 1 endometrial carcinoma, no significant comorbidities, she has completed her family. Okay, most appropriate primary management for her. So this is a woman who has a low risk disease. Stage is 1A1 and it is grade 1 endometrial. She has completed her family. So you will offer her total hysterectomy with bilateral salpingo oophorectomy. Okay, because this is the standard treatment for low risk early endometrial carcinoma. There is no LVSI in stage 1A1. So that is why no lymphadenectomy is required. Now coming to the question of whether the ovaries should be removed or not removed, of course, that is an individual decision, like after proper counseling of the woman. If she is at a high risk for any ovarian disease, usually bilateral salpingo oophorectomy is offered, and of course, explaining to her all the risks and the pros and cons of leaving the ovaries behind. So, but the standard treatment usually is total abdominal or laparoscopic if you have good surgeons for that. So total hysterectomy with bilateral salpingo oophorectomy. That is the standard treatment for low risk stage 1A1 disease. Okay. So these were a few important points about endometrium. The women, those who are at a high risk of developing the disease, the new staging, the FIGO 2023 staging, and how you are going to manage. So I hope you found the video helpful. Thank you so much for watching the video, and good luck to all of you for your exams. And like I always say, help us to help you crack this exam. Bye-bye and take care, all of you.